I just want to first really take this opportunity and ask Flasco, an organization, and Dr. Tan, who have included pathology as a part of your multidisciplinary really course today. Pathologists are often not called upon to talk about what pathologists do and what is the impact that we make in practically taking care of your patients. So that is really first for me, and I'm really delighted to be here and speak about what pathologists do. So my plan is to provide an overview of the contribution of the pathologist in patient care, research, and education collectively. And the most important thing is to really start with what pathology is. When we look at definition of pathology, pathology is the study of disease and the changes that it can cause. And a pathology report often is the story of the illness of an individual. So in many ways, if you want to make it simplified, that what pathologists do, we like people that they have the crystal ball. For a variety of reasons and with different tool that we have, we can take a look at that the story or the illness of a patient and try to identify what exactly the patient has. And in many ways, we can also like a fortune teller to forecast the future of that patient. What is going to happen next when the diagnosis is made? And this is what fundamentally the function of pathologists are in a variety of different areas of patient care, and particularly in oncology. So what does a pathologist do? We study fluid, tissue, and other material from the body, whatever that is being sort of taken out as a biopsy, surgical specimen, body fluid, anything that it can be a part of a body of a patient, that is often sent to the pathology department so we can take a look at it, examine it, and see what is the nature of that specimen. We provide diagnostic information, also prognostic and predictive information, meaning that not only say that this is cancer or not cancer, but if it is cancer, what kind of cancer, and what is really the characteristic of that tumor upon which individualized therapy can be practically planned. We assist our physicians in making decisions in respect to treatment planning, and we perform minimally invasive sampling procedures such as fine needle aspiration biopsy. We participate in research, we participate in medical education, and we perform autopsy. So this is a sort of a collective, sort of a panoramic view of what pathologists do. And of course, based on where they practice, the component or the percentage of the time that they spend in different areas is different. If they're in academic institution, maybe a good portion of their time is in research. If they are in community practices, maybe just providing diagnostic and prognostic information, practically make the most component of their time that they're there. We have different type of pathologists. We have anatomic pathologists, which they study tissue samples, and we have clinical pathologists that they study non-tissue, things like blood, urine, body fluids. So there are different kind and different really specialties that is involved in this discipline. We also have subspecialty in pathology. And one of the reasons that I put this picture particularly is try to demonstrate the fact that pathology discipline is the most unrecognized discipline in medicine. Not only public don't really know what we are doing, but also even our colleagues often don't understand exactly what to do with us. Their expectation is the fact that we stay in the basement and give them just the report and don't even see the sun, and they don't even understand and comprehend that we really are partner in clinical care, because without that diagnosis, without the information that we provide our clinician, they have no ability to treat a patient. And of course, this is something that it has taken all my life to try to really work against that concept across the globe practically, because every time that people talk about pathology, their perception of what we do is different. And one of the reasons that I have put this Quincy in here for you is because I travel a lot, and you see from my accent, I have an accent. So I'm a pretty good target for people to strike a conversation with me. There are two most important questions they ask me. Okay, where are you from? So you have to talk about the story of your life. And then what is it that you do? And the minute that I tell people I'm a pathologist, you can clearly see in their eyes that they have this unbelievable look for two reasons. One is the fact that they probably feel sorry for me. Secondly, is the fact that you can see the Quincy is sort of walking through their brain, and they are trying to find a way that they can see a similarity between me and Quincy. And thanks God that we're not similar. But the fact remains that Quincy is really the face of pathologists. And forensic stories that talk about investigation and finding the cause of death and all of that is what the general public really know about pathology. Whereas the forensic pathology and autopsy and all of that is a very small portion of what the pathologists do. And some pathologists, they don't do that at all, including myself. Therefore, pathology practice is something that is very wide, is expanded, and there are subspecialty in different areas. So after we finish medical school, there are 4 or 5 years of training to become just a general pathologist, and then you go to subspecialty of a year or 2 to become subspecialty in order to provide the best care that we can provide for our patients. So what are the different subspecialties for you to just know? These are listed in here, and every one of these components naturally has its own curriculum of a year that they have to exclusively concentrate on the issues that related not only on diagnosing these cases, but also what that diagnosis does in respect to the patient care. And one of the things that I am very proud to have done that, first of all, when I came on board at University of Florida and they asked me to run the department, I asked them for 35,000 square feet space, new space. In the first floor, the new East Wing expansion of the building, and I asked them that to let me design it myself. And of course they look at me and said that you're too expensive, we cannot afford you. And I said that give me 10% of what you want to use, but let me do it the way that I want to do it. And what I did is try to provide a comprehensive integrated pathology and laboratory service that they are connected together in one floor so people can access that. And in that scenario, the concept of us to smell like a formaldehyde, or for that matter to be in the basement or go up and run from one building to another is not present. And the concept is try to demonstrate that pathology is important because that deals with the patient care. And accurate diagnosis is the core and the foundation of a quality patient care. That's the reason that it's important for you all to go and get to know your pathologist, become friends and understand that, because you're going to learn so much more about your patients that you can really better help them. And within this area, within our department, we have all of these subspecialties, and I have a fellowship program in cytopathology, transfusion medicine, as well as breast pathology, because we want to train more of the people that are focused in different areas of pathology. Well, there has been a lot of change in the role of pathologists, as I indicated. Pathologists were often in the basement, they were men, they were sort of pretty much removed from the scene, so to speak. And the pathology diagnosis was based on just looking at the case, a light microscopy, and the most common diagnosis was undifferentiated malignant neoplasm. There was no more information about what is really the nature of this disease and what do they need to do with that. So through the years, emergence of new technologies, molecular characterization of tumors, a stratification of therapy based on tumor characteristics, and a paradigm shift in patient care and patient outcome. All of that resulted to the fact that the discipline of pathologists really expanded to that status that right now that has changed. Pathology has become a very viable and very participatory specialty with all people involved in the process, and often, again, they are quite articulate, they're quite active in participating as a member of the patient care. So what do we need to do? Right now, the expectation of our scientific community and patients is we need to not only establish a diagnosis, but whether this is a benign or whether this is a neoplastic process. When we make that distinction, then we need to establish a diagnosis, classify a neoplasm. We need to know exactly where the tumor is coming from and what kind of tumor they are, because tumors are not the same in every individual patient. Every cancer is different, and there is a family of cancer, family of abnormalities that we collectively call cancer. And that concept and that idea is no longer really accepted, because that is the reason that we are working through the process to provide that individualized and individually tailored therapy for individual patients based on the tumor characteristic of each individual case. So we need to also differentiate a primary tumor versus a metastasis. The patients come that there is no history of primary cancer anywhere, and they present with a lesion that you need to know whether this is really a metastasis, is coming from somewhere else, from an occult cancer, or this is really basically a primary cancer of that area. We have to predict response to therapy, provide prognosis, and of course compose a comprehensive pathology report. No longer just calling something as benign or malignant really serves the purpose for the management of the patients. We know, and we have to be very specific about a lot of information, a lot of detail about individual tumor, that they are helpful in how the clinicians are going to treat the patient, what kind of communication they are going to have with their patients, and what will be the outcome of that patient. When we talk about pathology report, it not only has to tell you what is the nature of that disease, what kind of cancer it is, we have to provide prognostic and predictive information. You know, as an example, if you call something cancer, then you need to, for example, breast cancer, it is important to have the information about the status of estrogen receptor, progesterone receptor, HER2/neu oncogene. These are the biological characteristics of each tumor that define a different kind of response to therapy. Therefore, the clinician need to have that information. This is just an example of, if I can get this one work, this is an example of fine needle aspiration biopsy of the breast that in the right side you see the malignant cells, and then on the other side you see that the tumor cells have this brown nuclear staining, indicating that these tumor cells are positive for estrogen receptor. Therefore, this tumor most likely is going to respond to endocrine therapy. So this is not as important that we say cancer or not cancer, but we need to see what kind, and we need to define the character of each individual tumor based on the available technology and information that we can have. When we are looking at diagnosing a cancer, we need to characterize a lesion. We have to be able to define and differentiate a lesion from benign versus malignant, and we have to recognize that that distinction is not always easy. There are a lot of lookalikes in pathology. There are a lot of gray zones there. That is the reason that it's important for us to make sure that the diagnosis of cancer is sort of confirmed by another set of eyes. A second opinion is a good idea because of the fact that we want to make sure that if we have the cancer, we know what it is, and this is really a cancer, and then we need to know how to how to provide the therapy for that. We talked about primary tumor versus metastasis, and there are tumors that they come, we know that they are metastasis from somewhere, and we don't know where is it coming from. We call it metastatic tumor of unknown primary origin. Again, these are all conditions that we deal with that, and every one of them require a different approach as far as the use of our diagnostic and prognostic tools. How do we do that? Aside from just looking at microscope, do a small, very simple H&E stain in the slide and look at it. When we look at it, and when there is doubt or when we need more information to better characterize the lesion, these are the listing of technology that right now is commonly available in every pathology laboratory. And the expectation is that the pathologists use this technology based on the need of that specific case in order to be able to really provide a good diagnosis. And if their own laboratory has no ability to do that, the expectation is that that laboratory find a CAP, College of American Pathologists accredited lab, and send it to those laboratories to provide the information. So right now, all of the laboratories in the country, in order to get paid from Medicare and CMS and all of that, they need to have accreditation by College of American Pathology. College of American Pathology has over 3,000 indicators that they would come and inspect you every 2 years. And every area of pathology, you need to comply with all of the requirements that they have in respect to the accuracy and quality assurance that is involved with laboratory testing. Pathology is the only clear, regulated specialty in medicine. So it's very important, it's very critical, and it's important for people to really understand the quality of the pathology laboratory that they receive. So if the laboratory has no capability of providing all of this technology and you are involved in cancer care, they need to find another laboratory to provide and act like a reference laboratory for you so that this information is available to your clinicians. I'm just going to give you some example, otherwise I'm not trying to teach pathology, but these are just example of cases that they come on board, and how do we use these ancillary studies to help us. This is just practically, a patient with a lymph node, enlarged lymph node, HIV positive patient. And we know that HIV positive patients, as immunocompromised patients, they have more susceptibility to have these opportunistic infection. One of them is tuberculosis. This is something that we see these days very often. So we see the changes within the morphology that we have in here. We see the abnormality, we see the morphology that look like a granuloma. We look at it at different kind of staining. And then you see these little red bacilli. These are the Mycobacterium tuberculosis. And when we see that by a very simple special stain, we have the capability of looking at this and say, okay, this lymph node enlargement is not due to lymphoma or cancer. This is infection. And tuberculosis is the reason for that. And that way, naturally, the patient is being treated with anti-TB drug, and that is how pathologists participate of the use of these ancillary studies. Give you another example. Patient comes, the same patient, similar story. A lymph node is enlarged. We even occasionally go with a fine needle, take some samples there, look at it under microscope, and we do what we call flow cytometry. Flow cytometry is an instrument that has the capability of classifying these tumor cells and tell us whether this is lymphoma or a reactive process. And if it is lymphoma, what kind of lymphoma the patient has. Therefore, in that setting, truly sometimes at 10 o'clock we do a fine needle, at 3 o'clock we have the diagnosis with classification of what kind of lymphoma the patient has. This is the B-cell lymphoma. This is, for example, you can see these cells, the nuclei are convoluted, they look like cauliflower, and this is characteristic of what we call T-cell lymphoma. Again, a different type of lymphoma, different prognosis, and different kind of therapy. So everything that we diagnose, we have to define it, exactly what it is, and what kind of therapy is appropriate for that special case. Now, what about cases that we talk about metastasis versus primary? How do we know that? The patient has breast cancer and has a lung lesion. And they sample the lung, it's cancer, but we don't know whether it's the primary lung cancer with primary breast cancer, or this is breast cancer that has metastasized to the lung. this is some of the things that the most important things to know this story. And the second component of that is the fact that we have to review the primary tumor and see whether there are similarities. If they're similar, then it's metastasis. If it's not similar, then we use some immunostain. So anyhow, so we do again a special staining to try to define exactly what the patient has. Give you an example. This is, for example, a young woman with this large breast mass. You can see the breast is really much larger of the other one. A simple fine needle aspiration biopsy that we did, you look at the morphology, they're different. They don't look like primary breast cancer. So this is when we use a different, what we call that immunostains, using different antibodies to try to define exactly what kind of antigen these tumor cells have. And based on that, make a diagnosis. This tumor, the brown staining tells us this is coming from smooth muscle, meaning that this is probably a leiomyosarcoma somewhere. And then we talk to the clinician. Well, the clinician said, yes, the patient has had leiomyosarcoma of the uterus. Very unusual, very young. But it is very important so that they don't assume that the patient has another primary breast cancer. It's a metastatic tumor. So most importantly, as a metastatic tumor, maybe mastectomy in this case is not going to really be very helpful. And they have looked at metastatic leiomyosarcoma and how best they can treat that. Another example, very simple example. Again, another breast case. Again, you see tumor cells. They look like signet ring. You see those red staining that they're mucin. They're telling us we are mucin-producing adenocarcinoma, which breast can have that. But we knew that the patient has colon cancer. So we did electron microscopy to see whether we can make that differentiation. And in electron microscopy, you see this tube. These are the villi that is only present in colorectal cancer. And then this is the primary tumor of the patient that has had colon cancer before. And this is metastatic to the breast. Unusual cases, but when this occurs, it has a major impact on our ability to really define what the patient has, and the treatment and prognosis is totally different. So this is where the art and science of pathology come into picture, and you have to have pathologists that they are very familiar how best they can use these ancillary studies to better define what the patient has. This is again another example. Most of my examples are from breast because that's what I do. This is a case that, again, metastasis to the breast is not a very uncommon process. Malignant melanoma is the most important metastatic tumor to the breast. In men, prostate cancer is the most common metastatic tumor to the breast. So in this scenario, if the patient has had history of a pigmented lesion in the past, and you see a mass in the breast, you need to stain it with what we call it melan A, that would define this as a malignant melanoma. And morphologically, you see that within the nucleus there is this internuclear vacuolization. You see a space there. That again is something that we see in malignant melanoma. So this is a metastatic malignant melanoma to the breast. Has nothing to do with primary breast carcinoma. Why is it important? It's important because of the fact that, again, if you have breast cancer, that by itself is going to make your children a high-risk individual for breast cancer. So defining the actual tumor that the patient has is going to be important in respect to that relation and the risk factor issue for the other member of the family. What about prognosis? What are the things that are important for us as pathologists to tell our clinician when they are dealing with the cancer? We need to talk about tumor size, tumor type, histologic grading, lymphovascular invasion, lymph node status, and a status of surgical margins. These are, again, a requirement right now in a synaptic reporting based on the College of American Pathologists requirement. Cancer cases require synaptic reporting with a very defined detail that is associated with the characteristic of each individual tumor. What else do we need to know? We need to understand what are the status of prediction of response to therapy. Assessment of the status of expression of estrogen progesterone receptors are important for endocrine therapy. assessment of the pattern of expression, or gene amplification of HER2 oncogene is important for Herceptin therapy. And of course, there are assessment of other new genetic pathways that is being discovered on a daily basis. Right now, for example, for non-small cell carcinoma, fundamentally, PD-L1 has become a very, very important really marker in order for us to have one more way to try to take care of the patients with advanced breast cancer, with advanced lung cancer. Now, what is the significance of accurate prognostic and predictive testing? This is for selection of those patients who will most likely benefit from systemic therapy, offering personalized medicine with greater safety and effectiveness and providing affordable and cost-effective care. Give you an example, Herceptin therapy is a very expensive therapy. I mean, I'm told that in a yearly basis, you're looking at $100,000 worth of money. But at the same time, it's toxic, cardiac toxicity and increased CNS involvement and all of that, aside from the other complications, are important issues for oncologists to really do. So we as pathologists, if we do not give the oncologist the precise assessment of HER2 oncogene and make a mistake and don't have the quality assurance issues to verify exactly whether this patient has gene amplification or gene expression and give the right answer, the patient either going to be deprived from Herceptin therapy, or the patient may undergo a very expensive and toxic therapy without having any benefit. So the responsibility of the pathologist in trying to give the right information to their clinician is unbelievable. It's probably more than any other field, simply because our oncologists and surgeons and the multidisciplinary team of the treating physicians, they rely upon us to tell them the information. And if we don't give that information properly, they're going to be misled, and the patient is going to suffer. And there are a lot of side effects, and cost containment in medicine is something that we need to be very mindful of that, because if we go the way that we are going, with the cost of medical care, the way that is escalating, I mean, we are going to collapse, because after all, there's a limit for everything. And that would require us to be very, very careful of what we do. The other things that the pathologists do, they can do tissue sampling. Fine needle aspiration biopsy is something that is considered the most cost-effective really sampling procedure. Nipple aspiration fluid cytology. The other things that I used to do as a part of research agenda was ductal lavage, and that is insertion of a small catheter within the nipple, try to aspirate tumor cells, and then try to define it and see what they are. Minimally invasive procedures to be, right now, really excisional biopsy for diagnostic purposes has really gone. Majority of the tumors right now, with having advanced imaging available to us, having core needle biopsy and fine needle aspiration biopsy as image-directed biopsy concept, they all are going to provide us a means of diagnosing tumors without having to do any excisional biopsy, and diagnosing benign lesions that they do not really require cancer therapy. In that setting, the patients often just go to the operating room with clinician know exactly what kind of tumor it is, what kind of therapy that they need, and what is really extent of the tumor that they need to take a look at it. So there is significant really advancement the way that we are doing business right now. There was a time that the patient would come with a palpable mass, and the surgeon would say, I will take you to the operating room, we take a portion of it, give it to pathologist. If that pathologist tells us it's cancer, we are going to do mastectomy. And the patient would go to sleep with a breast, would come back, there is no breast. And there was no time for this woman to really understand what are the options or what kind of it. And I'm the first one to admit that we as pathologists have made mistakes in making some of these diagnoses of cancer for patients that they have had mimickers of cancer. That practice is no longer there. I mean, we diagnose patients prior to any kind of cancer therapy, because every case is different, every patient is different, and every patient deserves that personalized approach, put all the puzzle together, and find something that is most appropriately really define that lesion and the patient benefits with consideration of the toxicity and associated with what are the benefits. That ratio is something that the clinician have that responsibility to explain that to the patient, and patients need to really know what is it that they get to there. So the concept of patients to be afraid to ask the question should not really be there. And I'm sure that you as healthcare providers are the best really agent to try to educate your patients about what they have and what they need to expect. So, as I indicated, the time of us getting the whole breast and diagnose cancer is really gone. We really diagnose these cases with a very small tumor cells, and we have the capability of defining what they are and how they need to do. So, breast cytopathology is something that naturally with core needle biopsy coming on board, fine needle has really gone to a different, sort of a little backburn. But for us as a breast cytopathologist to be able to diagnose a case of fine, we have to have the capability of understanding breast or other areas very, very comprehensively, because fine needle aspiration biopsy is practically looking through a keyhole and hoping to see the entire room, because your samples are limited, and then you have to have the capability of making precise diagnosis morphologically and use that small sample to try to define the biology of that tumor. Advantages of fine needle aspiration biopsy is the fact that provided diagnosis when surgical biopsy is not available or cannot be available, high expectancy and cost effectiveness. And believe me, still I live and work, I've always been there at UNICEF Florida Chance, and we are still seeing patients such as this in our emergency room, which is really a slap in our face as a community, that we allow the patients to really go and become that advanced cancer and they appear in emergency room before access to the care is there or before education is there, so that the patient would really come and benefit from this unbelievable amount of wealth of information and knowledge that we have right now. And when breast cancer, for example, is detected early, it is very manageable and is no longer really a fatal disease in the majority of the cases, and is a chronic disease. So we all need collectively to work through that awareness that is associated with all this malignancy and do a better job. This is just ductal lavage that I mentioned, that you put a small catheter in the nipple and then you pull the sample out of that nipple. It is not as bad as you think that they are. Actually, patients tolerate that with a great deal better than I had expected that. And this is, these are the cases that we have seen that you see morphologically that they look like a papillary lesion. There are people, especially in North, that they do endoscopically directed biopsies of this lesion. And then they see this small papillary growth, we call it intraductal papilloma. So some of these new technology and new advances has given us the tool that we have to have in order to better define what the people have. This is just an example of this ductal lavage, just for you know that these things are possible. This was a patient who had bloody nipple discharge, and one of our surgeons from outside hospital, our own institution, sent it to me and said that, can you do something with this patient? The patient doesn't really have anything mammography, nothing on the ultrasound, no risk factor, nothing, but has this and is bothering her. So when I look at it, and the ductal lavage, I saw these abnormalities in these individual cells, and then I did some immunostain to verify that this is cancer, and I told the surgeon that your patient has breast cancer. And he told me that, how in the world you want me to put a knife on the breast of a patient who has nothing? I cannot palpate anything, there's nothing ultrasound, there's nothing on mammogram. I said that, well, that become your problem. But this patient has definitely 100% cancer. Go and do the ductectomy. Take out the entire ductal structure around the nipple and let me take a look at it. I said that, what if there was no tumor? I said that, then you can take my license, because I know that this is tumor. It has all the characteristics that is associated with that. And this is actually a cancer that is arising within ductal system. This is one duct. This is where that nipple discharge was coming from. And this is the earliest ductal carcinoma in situ that I have ever diagnosed in my life. So these things are possible, these things are difficult, but when it really occurs and you make this kind of diagnosis, you really make a difference in the life of the patient. So don't look at these things as impossibilities. These are all available and these are all appropriate. How am I doing time-wise? Okay, I'm good, okay. So now that you have learned what I'm doing as a pathologist, or what pathologists basically do in everyday things, I want to talk about that. What do we as a pathologist need to provide our colleague an accurate pathology report? It's a bilateral process. It's two-way street. You cannot do it in vacuum. We need information. So what do we need to do? We need to receive the information from our colleagues about the type of the procedure, pertinent clinical history, age, risk factors, the site and the size of the tumor. You will be surprised how many times you receive a specimen that even the site is not identified. You don't know where is it coming from. History of other malignancies, history of chemo radiation therapy, pertinent laboratory and imaging finding, and appropriate tissue orientation so that we know exactly what do we need to look at it, and that is mostly in respect to the surgical margins that are very, very important in respect to the chances of recurrences in different tumors. The most important thing is effective communication. People need to talk to each other. That can be done through writing on requisition form, that can be through the computer, that can be through the phone conversation, but we need to have effective communication between pathologists and clinicians. Knowledge about the biology of the tumor and the impact of the pathology report on the follow-up treatment intervention and patient outcome require effective communication. We need to include appropriate scientific references at the end of the report, and following the current established pathology guidelines and participate in tumor conferences. Fortunately, almost in every cancer program, in every really medical centers, there are specific tumor conferences for everywhere. You have it for lung, you have it for head and neck, you will have it for breast, you have it for GI, where all the people, radiologists, pathologists, clinicians, oncologists, surgeons, they get together and actually talk about individual patients and collectively make a determination as what the patient has and what is the best type of therapy. If we as pathologists are confronting with a tumor or a lesion that is rare and we don't know what it is, first of all, we need to send it for second opinion. It's always good to make sure that the patient benefits from experience and knowledge of someone else. So that's number one. There is nothing wrong with second opinion. The second component is the fact that the pathologists often, what I teach our fellows and residents, write a very small paragraph as what this tumor is and what kind of therapy are now recommended or available, and put references so that the clinician, when they see the report, they would be able to go online and then look at the references and become knowledgeable about the entire concept of pathology of that specific case, because you cannot expect everybody to know everything. So your pathologist should be that source of education and information to your clinician so that you can better talk to your patient, better educate your patient, and then at the same time better make a decision as what is the most appropriate therapy for that specific patient. Now, I'm just going to finish my talk with this concept of what is really the current practice of cancer. And this is something that is promoted all over the world. And that is, we need to integrate our resources. Whether it is going to be a one cancer center, one breast center, or this is virtual. You have different components of your care in different parts of the institution, or even different location. But you have the ability to communicate with each other. In that setting, it has to be patient-friendly, and it has to be cost-effective. And in that scenario, you can see it really starts with navigators and coordinators who play such an important role in trying to help the patients where to go and what to do. And if they don't know how to ask the question from the clinician and their physicians, they would have the ability to talk to you. You're the key. You're really the cornerstone of the ability of the patients to really better understand and feel comfortable of the information that they receive. So these are the specialties right now that is really required for taking care of cancer patients across the board. We need radiologists, pathologists, surgeons, medical oncology, radiation oncology, plastic surgeon, genetic counseling. Psychosocial support is a very important thing that has been forgotten. We have to make sure that every institution has some degree of research and investigational work. They have some metric that they look at, what is it that they do and how they can better the course of therapy for each patient. And of course, patient and physician education and survivorship are important component of really cancer care. And this is something that we naturally advocate and hope that no patient really is treated in a sort of a single, physician office anymore, because cancer is a family of disease and it requires a family of physicians to take care of it. And thank you for your attention.